Really did scare me, but I was in capable hands, and when I found out the diagnosis was not bad in as much as that they can cure it, and the odds were in my favour, I was a lot more relaxed about it, so I didn't panic. But the big C, obviously, you know, it does scare a lot of people, and it has taken a lot of people in the past.
That biopsy did show that, of course, there was a cancer in the lining of the bladder, for which treatment would be necessary.
I was stunned, but it was actually that. I'd had it in the back of my mind, a possibility, but I suppose I felt reasonably upbeat it was going to be something else. So I came out of his room totally void of any sort of feeling. I didn't know what to say, so I got Carol and...
His face was ashen. It was just...
She said, "Oh, what's up, son?" I just sort of pulled her to come with me, and then said, "You know, yeah, it's cancer."
This film will help those people who are already on or just about to start a treatment journey for high risk or high grade non-muscle invasive bladder cancer. Non-muscle invasive bladder cancer is also sometimes called superficial bladder cancer. Doctors and nurses will always provide a lot of information and discuss at length the different treatment options that are available. They can also offer information leaflets. We hope that this film will be a helpful addition to information you already have. It not only goes over some of the facts around non-muscle invasive bladder cancer, but importantly shares the experiences of other people who are going through a treatment journey for high-risk, non-muscle invasive bladder cancer. We're grateful to those individuals who have agreed to tell their stories.
The film is produced by the Bowes Section of Oncology and the British Uro-Oncology Group, or BUG. Whereas these two organisations are focused on information for the medical profession, we recognise the need for doctors and nurses to offer as much support as possible to people who are undergoing treatment, along with their families and friends. Unfortunately, it is not possible for our organisations to provide direct patient advice, but in the chapter More Support, we have provided details for other sources of direct help. We would always advise that people speak to their own doctor or nurse with any specific questions or concerns.
I am an optimist, and I believe that the treatment will be successful, and that's how I go through life.
I just thought, I've got to fight this. You know, I believe in life is for the living, and I thought I've got to fight it. And I did know a bit about it because one of our family members has the same problem.
You know, it's been such a journey, but I see now, for me, I'm seeing the light at the end of the tunnel.
And I found the more people I sort of spoke to about it, the easier it became to accept it and get on with it. And everybody's been absolutely great.
Even we've had people that know someone that's had it and been cured, and that sort of thing, which was great. You know, the more people you tell, the more you get back from, you know, information-wise and that from other people.
Around 10,000 people are diagnosed with bladder cancer every year in the UK. It is the 4th most common cancer in men and the 11th in women. Bladder cancer is quite rare in people under the age of 40, but a person's risk increases as they get older. So why are we focusing our attention in this film on high-risk, non-muscle invasive disease? Well, of the 10,000 new cases of bladder cancer in the UK each year, the majority, that is 70 to 80%, are non-muscle invasive tumours. Although many of these tumours can be effectively treated, the risks of the cancer returning and progressing to invasive disease can be quite high without appropriate treatment. The main aim of any treatment for bladder cancer is to remove the growth as early as possible and prevent the cancer returning and progressing in the future. For non-muscle invasive bladder cancer, the urologist will usually advise an operation, either a biopsy or transurethral resection of the bladder tumour, sometimes called a TURBT. A biopsy involves taking a small amount of tissue from the bladder that is then checked in the lab and can help determine the following treatment course. The aim of a TURBT is to remove the cancerous growth completely. Even if a TURBT is done, it will be important to have check operations similar to the biopsy or TURBT on a regular basis to assess what is going on in the bladder following treatment. After a biopsy or a TURBT, you may have an immediate dose of chemotherapy to help the progress of the operation.
For some types of tumour, a course of chemotherapy will be recommended. For high-risk, non-muscle invasive bladder cancer, it's very likely that the doctor will prescribe a type of immunotherapy to significantly decrease the chances of the tumour returning or progressing. This immunotherapy is called BCG, which stands for Bacillus calmette-guerin. BCG was originally developed as a vaccine, but was later found to be effective against non-muscle invasive bladder cancer. The treatment works by encouraging the body's own immune system to fight the tumour. Immunotherapy is different from chemotherapy, which is commonly given for low or intermediate risk non-muscle invasive bladder cancer. BCG immunotherapy generally involves an induction course and a maintenance course. The treatment is commonly given by the specialist nurse. The first stage of treatment is called induction. Induction treatment begins about 2 weeks after a TURBT. The treatment course is 6 doses of BCG over a 6-week period, that is 1 dose every week. Then there will be a treatment break for 6 weeks, and the bladder is checked for tumours during this time. After these 6 weeks, 1 dose every week is taken for 3 weeks. After completion of the induction treatment course, the maintenance stage is introduced. The maintenance course is different from induction. It involves 1 dose every week for 3 weeks. These doses will be repeated every 6 months for up to 3 years.
BCG is a standard treatment for high-risk, non-muscle invasive disease, but the treatment schedules must be followed for it to work.
Before any treatment dose with BCG, it is recommended not to drink any fluids for 2 hours. If you take diuretics or water tablets, you may be advised to take these after your treatment. The BCG is given by the doctor or nurse placing a catheter into the bladder to drain away any remaining urine. A bag containing the dose of BCG is then attached to the catheter and the treatment is slowly delivered into the bladder. This dose of BCG is called an instillation. The catheter is then removed.